Uh, a very warm good evening to all the esteemed faculties and all the participants. Thank you for joining. This is Sahiti from Shield Connect, welcoming you all for today's webinar on neurological problems in pregnancy, organized by Safe Motherhood Committee of Oxy. So let me welcome the MOC of today's webinar, Dr. Sneha Sethumadhavan. Ma'am is currently Junior Consultant at CSI Kalyani General Hospital, Mylapore, and ma'am has received many gold medals, including Mary George Gold Medal for Best Outgoing Student, and Dr. Bhaskar Rao Gold Medal in OG for DNB Final Exam, and Mrs. Indumati Javeri Prize for Best Oral Presentation, and Dr. Jayashree Gajaraj Yuva Oxy Orator Award. And ma'am has special interest in labor room management, fetus surveillance, and high-risk pregnancy. So let me welcome MOC, Dr. Sneha ma'am, and I hand over the session to her.
Thank you so much for that kind introduction. Good evening, one and all. On behalf of the Safe Motherhood Committee of Oxy, I would like to extend a warm welcome to all of you on today's CME, Neurological Problems in Pregnancy. As practicing obstetricians, coexisting neurological diseases are something that comes along far and away, but it is not completely null and void. And when we do come across such a case, we should be armed with the right clinical resources, and I hope today's CME will benefit you all. I would like to start with the Tamil Thai Valthu. Thank you. Can we proceed with the lamp lighting? Thank you so much. I would like to call upon Dr. Jairani Kamaraj for the welcome address. Ma'am needs no introduction. She's our beloved Oxy president. She's a senior consultant at reproductive medicine at Akash Fertility Center, Chennai, and she holds multiple office posts in Indian and international medical organizations in fertility and sexual health. She's been awarded many accolades and won many noteworthy gold medals. Over to you, ma'am.
Thank you, Sneha, for this nice introduction. Anivarukkum Malai Vanakkam. Hearty evening wishes to one and all. On behalf of Oxy 23, as a President Oxy, I have the great pleasure and honor to welcome all the senior OGCians and especially the chief guest, Dr. Ashwath Kumar, who in midst of his so much of busy schedule has accepted to join and give us very special wishes for us. And it is a very, very important one that you are here, sir, which gives a very valuable importance to this webinar. And thank you so much for being with us. And it is a very great pleasure to have you here, sir. We welcome you, sir. And a very, very special welcome to our another chief guest, Dr. Kiran, sir, who is not here, but who has immediately accepted to be our guest of honor. And it is a very great pleasure to have all the great obstetricians are all the great Foxians here, who are the past presidents, who are the presidents of these federations, to be here in our webinar of Foxy, in which I think Rajshri needs a very special applause, because she has been doing a lot of work in Safe Motherhood Committee, along with many societies all over the country, involving all the senior faculties at the same time, all the other specialties together into the obstetrics and gynec. Because we all know we cannot practice alone, it's a teamwork. Many times we need all the help of all other specialities to hand in hand to save the mother and child, which is our aim of any physician. So in this work, Dr. Rajshri is doing a wonderful work of coordinating all the specialty, like gastro one time, surgeon one time, and now we have here the neurologist here to have a great coordination of all the work that we both go together. And we have a lot of senior faculties here, and I have a special welcome note to the senior faculties, Dr. Ushavi, Dr. Jaya Vijayaraghavan, Dr. Lakshmi Narayanan, who is a senior neurology HOD, and also Dr. Dhanlakshmi, Dr. Tamil Pavai, who is the associate professor in MMC, who is a neurologist, and also all the senior persons, especially my good friend Dr. Kanjan here, who has all the way has accepted to be the person who is the NCD committee chairperson elect, who is a very, very dynamic person working in the obstetrics, and also great people like Sunita, Samal, and Jayavi madam, all are here to share their experience, expertise, and knowledge in this content of neurological problems in pregnancies and in the women management during pregnancy. We welcome you all on behalf of Oxy 23. I welcome you one and all for this webinar. Can we go ahead with the inauguration? I have the great pleasure and honor to welcome Dr. Ashwath, who is a very good friend of mine, a very senior physician, a very dynamic person of Foxy, and a very humble man, and a very nice man, accepting everything with a smile and doing a lot of work for Foxy as well as for the Kerala Federation. He has done a lot of work in laparoscopy, and sir is the present Federation President elect for the Kerala Federation of OBGYN, and he was the past Vice President of Foxy, and he chaired the Swiss Foxy Committee and also the President of Foxy in 2019. And he has done a lot of work in OBGYN and laparoscopy. Over to you, sir. Thank you for being with us, and we'll be very happy to have your word of wisdom, sir. Sir, unmute, sir. Sir, you're muted, sir.
Okay, now it is clear?
Sir, yes, sir, yes, sir.
Now we can hear you? Okay.
Yes, sir. Yes, sir.
Okay. I'm sorry that I am in the OT, so slight disturbance is there. So anyway, thank you so much, Jairani madam, Dr. Kundavi, Dr. Rajshri, the Safe Motherhood Committee, OGSSI, my guest of honor, Kiran Kothari, and Kanchan madam, and all the senior faculty members and the neurologist present here. You have selected, I'm so happy to be here. There is some reason of this topic, neurological problems in pregnancy. See, my wife is having migraine. Okay. Both the pregnancy was so bad. She had many times admitted in neurology department and I was having a headache during the time because it was so you have taken, headache as when I saw the topic itself. For me, I understood that it is not a small topic and not easy to manage in pregnancy. Lakshmi Narayan sir has come to, whenever I think about neurological problem in pregnancy, first thing a patient comes with seizure, first thing comes to your mind is eclampsia. I will tell you two incidences which I have seen. One was a patient came with a convulsion, and BP was in the borderline. So we all thought that it is eclampsia itself. BP was about 140/90 and all. Then later MRI showed multiple brain mets actually. So that was one reason, one thing. Another which I saw was the patient patient had a fall actually. This is about last month only. Patient had a fall and came. she was having a intracranial bleed with the convulsion. So patient came, all these patients come and like unconscious come to the, so they thought that it was, we all thought that due to eclampsia, patient had a fall and she had a injury. But actually, patient did not have any eclampsia or anything. No history of PAH. Patient had a fall and fall has created. So all these topics which you have taken and multiple sclerosis, topic which all of us should know. Many of us don't know what is even multiple sclerosis. So thank you, madam, for selecting the topic. It will be a great. I will be listening to it in the recorded version. Maybe immediately I will finish my cesarean and I will sit and listen to you. Once more, I thank you so much for inviting me as the chief guest for this program. Thank you. And always OGSSI and my relation, whenever they have called, I have been here for so many programs for the last 20, after my passing out, maximum, I would have visited the Chennai society only. So Jaya madam is there, Dhanlakshmi madam is, so many people are there who are known to me for years actually. So Kanjan madam, my friend in Foxy. So thank you all for making me a part of such a wonderful program. Thank you, madam. Thank you.
Yes, sir. So please log in whenever you finish. Please log in, sir. Thank you. Thank you.
Thank you, sir.
Okay,
Thank
I
you.
will log in as I finish the case and I will log in immediately.
Thank you, sir. Thank you for being with us in midst of your emergency. I have the great pleasure and honor to welcome the president elect of MOX, Dr. Kiran Kritikoti, sir, who is not here, but definitely we need to have a CV. Can we tell a few words about sir? Yes. Sir is the ex-chairperson of the MTP committee of Foxy. He is the president-elect of AMOX, and he has been the managing council member of Pune OBGYN Society of since last 22 years. And he is the ex-chairperson of the MTP committee and chairperson of the Medical Education Research and Training. And he had a lot of publications for his credentials. Among the Suraksha booklets in AMOX, he has edited the medical abortion of the Foxy Focus, and he has authored Medical Abortion Drug Regimen and RPL Foxy Focus. And sir, thank you for being with us. And I hope that he will log in at any time to wish us. And over to Rajshri to carry over the academic sessions. And a very special thanks to Kanchan. I think Rajshri, you can introduce Kanchan.
Yeah, ma'am.
Thank you.
Welcome, ma'am. Ma'am is the chairperson elect of NCD committee, and she's the secretary, Kanpur Obstetric Gynec Society 2021 to 2023, president IHR of Kanpur, ART specialist laparoscopic colposcopist, and she has several awards to her credit, and she has organized several academic events also. And it's really an honor to have you here, ma'am, as an expert. But since you said that you have an emergency, just give us a few words of your wisdom, ma'am.
Thank you very much. First of all, my congratulations and much of appreciation to Dr. Jairani and Dr. Rajshri. Dr. Jairani, as I know since long, she is very much devoted. She has much of willingness to give lot of time and energy, as because of her, this OGSS is flourishing like anything. And I talked to Dr. Rajshri. I have seen even your vision that you are working very hard, and my good wishes are there. I think the topic chosen are very good today, and these type of topics are now being included in non-communicable diseases. So pregnancy with these type of topics like migraine, headache, and convulsions, these type of the patient, really we need to give time into it, because many times the patients with the convulsions, they come to us independent of the reason, that is eclampsia, preeclampsia, independent to them. The patients, they are with the convulsion, and with the pregnancy we have to change the medicine, whether we refer them to the neurologist or we have to change the medicine. So this is very important topic, and my best wishes to you, and we'll love to do work with your society even in the future for further non-communicable disease. Thank you so much.
Thank you for your time and readily agreeing to be a part of it. Please log in if you can in between. Thank you.
Yeah. Thank you very much.
Neha, we will continue with Oxy prayer by our secretary, and then we'll move for the session.
Okay, ma'am.
Kundavi ma'am is there. Ma'am, introduce her, ma'am.
So we'll have the Oxy prayer by Dr. Kundavi. Again, she needs no introduction. She is the Honorary Secretary of Oxy. She's the HOD and Senior Consultant at IRM MMM with vast experience of more than 20 years. She's a member of multiple renowned fertility organizations, and she's been a faculty at conferences, and she's also has many publications to her name. Over to you, ma'am.
Ma'am? Ma'am?
Kundavi, ma'am?
She had logged in.
Yeah, she's there.
She's muted, huh, Sahiti?
Yes, ma'am. I have given request to unmute.
She was there. I saw her. That's why. Ma'am?
Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, ma'am. Thank you. Yes, Neha.
Thank you, ma'am. So without much further ado, let us start with the much awaited scientific session for today. We are very much privileged to have a very seasoned and experienced neurologist amongst us today to enlighten us on today's topic. I am very happy to introduce Dr. Tamil Pavai. She is the Associate Professor of Neurology at MMC and Consultant Apollo Clinic, Anna Nagar. She's also a member of various neurological societies, and her area of interest is movement disorder and cognitive neurology. She's the co-PI in ICMR task force in multiple sclerosis. We are very happy to have you here, ma'am.
Yes, ma'am. Welcome, ma'am. You can share your screen, ma'am. Ma'am?
Only 1 minute. Yes.
Okay. Okay.
Please click on share screen option, ma'am.
Yeah, I've just clicked on it. Yeah.
Yes, ma'am. We can see the slides, ma'am. Can you make it full screen, ma'am?
Only 1 minute. Only 1 minute. Sorry for that.
Ma'am, you just have to click the slideshow option, ma'am.
Yeah. Something with me. Just wait.
Yeah.
Sorry.
No problem.
Good evening, one and all. I thank our director and my mentor, Professor Lakshmi Narasimhan sir, for giving me this opportunity to speak, and also thank all the members of this OG committee. I would now like to talk on this multiple sclerosis and pregnancy. Historically, Women with pregnancy in the childbearing age group were discouraged from becoming pregnant. But the history has changed in the late 1990s, where the seminal PRISMS trial came and so many disease-modifying drugs were introduced into the market. From then on, women now start conceiving and also have a safe confinement and a safe delivery also. There are so many DMDs and not all of them are potentially safe. So what happens? So when you cannot introduce all the disease-modifying drugs in pregnancy because of the risk of teratogenicity. It seems sensible to stop the disease-modifying drug before pregnancy, but the problems of rebound relapses and increase in disease activity are likely to occur. So how do you focus on multiple sclerosis in pregnancy? The management of women with multiple sclerosis of childbearing potential would be to do a pregnancy planning, pregnancy, postpartum period, disease activity, impact of therapy withdrawal of the disease, effects of multiple sclerosis therapy on the fetus, and there are plans for breastfeeding. So this impact of pregnancy of the MS disease activity called the PRIM study, Pregnancy in Multiple Sclerosis, is a major landmark study which has revolutionized in the of women getting pregnant in the reproductive age group with the disease. So they found that there is a decrease in the annualized relapse rate during the third trimester of pregnancy. That is 0.2 compared to 0.7 in the year before pregnancy. And there is an increase in the ARRR during the first 3 months postpartum, 1.2 compared to 0.7 in the year before pregnancy. So that the the postpartum period was similar to that in the antepartum. And what are the causes for the early postpartum relapses? There are many factors which have been identified. The higher AR in the 2 years before consumption, the number of relapses during gestation, the higher EDSS score. This is an disability score which is used for scoring the disease progression in multiple sclerosis, and there is no history of DMT use 2 years before conception. And the active pre-pregnancy MRI, which is independent of disease activity prior to conception of delivery. Women taking DMTs for a minimum of 8 weeks during pregnancy carried a decreased risk of postpartum relapses compared to not taking any DMT during gestation or in the trimester before conception. So when you have a relapse during pregnancy, how are we going to treat it? You have to avoid corticosteroids in the first trimester due to the increased risk of fetal malformations such as rough palate. But if the disease is going to be active and disabling, you have to give a short course of high-dose methyl prednisolone. They are the ideal first treatment choices, as they are relatively safe during the second, third trimesters also, and should be exclusively used only in case of severe relapses. And for disabling cases, you can do plasma exchange with a very low associated risk. We cannot use dexamethasone or betamethasone because of adverse effects to the fetus concern and not for the disease relapses. So if any patient comes with multiple sclerosis with relapse during pregnancy, we give a short course of IV methyl prednisolone. What is the impact of pregnancy on the multiple sclerosis disability progression? The total number of pregnancies in an MS patient's lifetime did not appear to have a negative influence on the long-term course of the disease. What is the impact of multiple sclerosis on pregnancy? What does the disease do to a pregnant woman? There is a high incidence for small for gestational age newborns and increased predisposition to urinary tract infections and constipation, and more frequent interventions to induce labor, particularly in women with a high disease activity, that is, who are having a high EDSS score. And regarding anesthesia, epidural and general, both of them are completely safe and they do not affect the risk of postpartum relapses. So what is the impact of disease-modifying therapy on multiple sclerosis? So what is the impact of fertility, which is being induced by this disease-modifying therapy? These are the injectable drugs, that is interferon beta, glatiramer, this dimethyl fumarate, fingolimod, sifonimod, doflunomide, and cladribine the oral drugs. And these are the new MABs, that is the monoclonal antibodies, natalizumab, alemtuzumab, and acrelizumab. They found there was no effect on fertility affection because of these drugs. And collateral they found only in animal studies. Sorry, something wrong with my sorry for this interruption. So in a woman with multiple sclerosis treated with a DMT who wishes to start a pregnancy or who have an unplanned pregnancy, what should be the treatment approach? Recommendations are: advise all women of childbearing potential that DMTs are not licensed during pregnancy except glatiramer acetate, which is a consensus statement. And for women planning a pregnancy, if there is a high risk of disease reactivation, you consider using interferon or glatiramer acetate until pregnancy is confirmed. In some cases, continuing this drugs during pregnancy would be considered based on a risk-benefit ratio. So what is suppose? So we told the two drugs, they are injectables. One is glatiramer acetate and interferons. So what are the outcome in interferon beta exposed patients with multiple sclerosis? These are the results from a European interferon beta pregnancy registry. That data gathered suggests there is no evidence that interferon beta exposure before conception or during pregnancy affects the increases the rate of congenital anomalies or spontaneous abortions in the newborn. So it is considered safe. Sorry. I'm in hospital, so I don't see something is. So what happens when you have an exposure in the first trimester? This is glatiramer acetate. There was no elevated risk of spontaneous abortion or congenital abnormalities, but exposure during course of pregnancy, there was no elevated risk outcomes. And interferon beta also, there was no elevated risk either in the first trimester or throughout pregnancy. What are the guidelines? So what are the EMA and FDA recommendations for the management of injectable DMTs in pregnancy? So initiation of treatment during the pregnancy is contraindicated. But once a patient is already on a DMT, you can continue until pregnancy is confirmed. And selective cases, highly active disease, it may be administered throughout pregnancy after careful evaluation of the risk-benefit ratio. Suppose if you want to give glatiramer acetate, initially there was a contraindication up to 2017, which was currently removed, and you can continue until pregnancy is confirmed, and you use continuous use in pregnancy, now supported in some cases. But there are so many studies which have been replicated in various studies. The patient continuing taking interferon beta or glatiramer acetate throughout the course of pregnancy. They found there was no increased incidence of spontaneous abortions or congenital. Patients were able to have a safe delivery and an outcome. So no relationship has been documented between the paternal exposure during interferon beta or gamma, that is glatiramer acetate, at the time of fecundation and the risk of adverse outcome. So what are the recommendations for the oral drugs? First, I told about injectables. Now, what are the recommendations for the management of oral drugs? That is dimethyl fumarate. So the risk is not elevated in the first trimester, that is spontaneous abortions or congenital anomalies. So what is the recommendation? You should stop with contraception and or a post-pregnancy test, because the short life of dimethyl fumarate is very short. So you can start it immediately. Suppose a patient accidentally conceives. What do? You justify the risk-benefit ratio. If their benefit is more, sorry, I'm very sorry about this. So you have to stop the drug, and if the accidental exposure, you have to not worry about it, and you can just justify the risk-benefit ratio with the accidental screening. With fingoline mode, you have to stop 2 months before conception, and at the same time, you have to give a contraception for 2 months before becoming pregnant. And cladoramine pregnancy is safe for 6 months after the last dose. So we don't have experience with using cladribine. We have got experience with dimethyl fumarate. So what are the recommendations? It is not recommended in pregnant women and in fertile women not using appropriate contraception. You have to discontinue before conception and maintain effective contraception for an appropriate time before pregnancy. You have to monitor the disease activity, see if breastfeeding applicable, and you have to resume therapy. As regards to fingo-line mode, women should not become pregnant and active contraception is recommended. Since it takes 2 months to eliminate the drug from the body, contraception should be continued for after 2 months for stopping the drug. So you should wait for a 4 months period before you can ask the patient to plan pregnancy. Now coming to the injectable monoclonal antibodies. These are the natalizumab, rituximab, ocrelizumab is recently been approved, and alemtuzumab. So even with natalizumab, the risk of spontaneous abortions or congenital anomally are not elevated. But when you continue during pregnancy, there are studies which tell there is an increased incidence of anemia, thrombocytopenia, low birth weight, increased first year hospitalizations, and cardiac pulmonary malformations are likely to occur. So when you want to continue natalizumab is given only for very highly active disease. You have to switch to a depleting agent before pregnancy. And rituximab also, they found there can be reduced B counts in newborns. And you have to wait for conception. You have to wait 1 to 3 months after the last dose. Suppose, and the patient is not going to conceive, you can redose it if they're not pregnant for 6 to 9 months. And same thing with ocrelizumab. That is, after the last dose, you can plan pregnancy within the first 1 to 3 months. Suppose a patient is not going to become pregnant, you can redose it for the disease. Alemtuzumab, you have to wait 4 months after the last dose for pregnancy planning. Suppose a patient accidentally conceives, you have to monitor thyroid function tests and anti-thyroid antibodies. There is an increased incidence of transmission of thyroid antibodies to the fetus and neonatal thyroid disease. So, recommendations for natalizumab, that is, used during pregnancy only if the risk-benefit is lower than the benefit. Continue until pregnancy is confirmed. Continued until second trimester in highly active disease. Resume therapy as soon as possible. Alemtuzumab, you have to maintain 4 months of contraception after the last dose and use based on a risk-benefit ratio. And ocrelizumab, that is, they have to wait for 12 months after the last infusion. You have to discontinue before conception and maintain effective contraception for an appropriate period before activity. You have to monitor the disease activity clinically by MRI and also by evoke potentials. So what is this natalizumab? Natalizumab is a highly active drug used in highly active disease. It is a monoclonal antibody which has been approved for the highly active relapsing remitting multiple sclerosis. It reduces the CNS inflammation by blocking the very late antigen on the surface of lymphocytes, thus preventing the transmigration through the blood-brain barrier. Since it is associated with the high risk of disease activation, pregnancy should be planned without interrupting the drug or with the strict monitoring of the conception. In practice, a patient-tailored approach is suggested, which can be either a conservative approach, semi-active approach, active approach. There are 4 approaches. So in a conservative approach, you discontinue natalizumab prior to consumption and maintain contraception for 2 to 3 additional months after discontinuation and then plan pregnancy. In a semi-active approach, maintaining at least until conception and test beta-HCG before each infusion 6 to 8 weeks after delivery, because you have to redose it every 6 to 8 weeks. Maintaining until the 30 to 34 weeks of pregnancy, or you can do an extended dosing regime also, and early restarting after delivery, that is 8 to 12 weeks after the last infusion. In a bridging approach, you switch natalizumab to a depleting agent like rituximab or ocrelizumab to prevent disease relapses or prevent the progression of the disease. So, current UK guidelines consensus recommend an active approach. So, what we should do? You can use natalizumab as well as a depleting agent, and this remains an off-label in clinical practice. All cases are decided on an individual case-to-case basis. So, women with persistent high disease activity would be generally advised to delay pregnancy. For those who, despite this advice, decide to become pregnant or who have an unplanned pregnancy, that is, treatment with natalizumab should be considered after discussion with the patient of the potential implication. For alentizumab, you have a planned pregnancy, that is, you have to provide a 4-month interval before planning the pregnancy after the last infusion until conception, and the disease activity as well as the pregnancy complication should be strictly monitored throughout the course of the pregnancy and even in the postpartum period. These are the ICTRIMS and EAN guidelines. So, women of childbearing age trying to get pregnant or not using a reliable contraception, you see whether the disease activity is under control clinically as well as by MRI. You optimize the treatment and reliable contraception for 6 to 12 months for conception, before conception. This moderately effective drugs being glatiramer acetate, beta interferons, dimethylfutrate, and teflunomide. We found that glatiramer acetate, beta interferons are safe with very first trimester exposure, safe to continue conception. But dimethylfumarate and teflunomide, which are oral drugs, they have to discontinue before or at time contraception is stopped. The highly active drugs are fingolimod, natalizumab, rituximab, alentizumab. That is, they have to hold infusions while pregnant, discontinue contraception for 4 weeks after the last infusion so that they can plan the plan pregnancy accordingly. Or you can use a chelating drug and plan pregnancy. So what happens in a first trimester exposure to MS treatment? Say there is what is the role for giving? Suppose a patient is having a moderate disease and you want to stop the drug, there is a risk of always a pregnancy relapse, which is going to affect the mother as well as the child. So we consider there is a low risk of pregnancy relapse if you give glatiramer acetate or beta interferons in moderately active disease in the first trimester. Dimethylfumarate and teflunomide used to be used with caution. But in a highly effective disease, there is a high risk of pregnancy relapse. So use fingolimod and natalizumab cautiously after discussing with the patient the potential risk of complications, and the patient don't agree with going with these drugs. You can ask them to avoid pregnancy and bring the disease under control and plan for a pregnancy, or use a depleting agent like rituximab or ocrelizumab. But when you use all these drugs, you have to monitor for liver function tests, your bone marrow parameters, as well as the that is B cell depletion markers like the CD19 count. Women that is progressive multiple sclerosis may similarly use B cell depleting therapies before conception to bring the disease under control. So these are the maps which have been tried. We found this natalizumab, alentizumab, and ocrelizumab can be tried compared to the other drugs. So what happens? So when you give natalizumab, there is suppose you want to stop, there is a high risk of rebound disease activity if stopped, can be continued until 34 weeks of gestation. Suppose if you're giving the drug, you have to check the infant for hematological abnormalities. And for alentizumab, the last dose 4 months before conception, and monitoring for autoimmune disease throughout pregnancy, close monitoring for neonatal Graves' disease. And ocrelizumab, last infusion with pregnancy is confirmed, or 3 months before trying to start with conceive. And you have to monitor the B cell counts also. Ofatumab, last injection when trying to conceive or when pregnancy occurs. Check infant for B cell depletion and delay live vaccines in infants until B cells repopulate if exposure occurs. And rituximab, last infusion when pregnancy is confirmed or 3 months before trying to conceive. So what are the consensus recommendations on avoiding rebound MS disease activity in patients receiving fingolimod or natalizumab who are intending to become pregnant? Patients, if they are receiving fingolimod and you found the patient has got a stable MS activity, you stop fingolimod and switch over to interferon beta, or you stop fingolimod and monitor regularly. Suppose the patient is going to be on a long-term planning option, you stop fingolimod, switch to cladribine tablets or alentuzumab. Short-term planning, you stop fingolimod and switch to natalizumab. These are the recommendations. Suppose a patient is receiving natalizumab, which is a highly active disease, you have to have an active approach. Continue natalizumab to 30 weeks gestation with the infusion intervals extended to 6 weeks. Or you can withdraw natalizumab on a positive test, especially if the mother's MS is well controlled. Not only are bothered about the drugs. See, drugs is one aspect, either an injectable, oral drugs, or a MAP. You also have to look after the ambulatory function and physical therapy once a patient delivers a child. Postpartum care is very important because there is an increased incidence of relapses, and women should also be evaluated for cardiopulmonary deconditioning, focal weakness, spasticity, and balance, which are very important. And exercise also may improve a mood postpartum. You have to also look into the bladder functions and pelvic floor physiotherapy, and urinary tract infection should be proactively diagnosed and treated. And you also have to look into the mental health and psychosocial well-being of this disease, because MS not only affects your motor part, it affects all parts of the brain, the cognitive neuroaxis also. So what is the role of the disease-modifying therapies to the breast milk and recommendations for use while breastfeeding? That is, injectables like glatiramer acetate and interferons are probably compatible because of their larger molecular size. The excretion is very low and the oral bioavailability low, whereas the oral drugs like dimethyl fumarate and fingolimod, because of their small molecular size and increased risk of transmission to the breast milk, it is not advisable to give this oral drugs while breastfeeding, but these MAPs are compatible, like natalizumab and rituximab. Now, so you have listened to the lecture. Now we'll go on to a case vignette. A 26-year-old woman with relapsing remitting multiple sclerosis presented to us in follow-up. She has been diagnosed with MS at the age of 18. Multiple modestly effective disease-modifying therapies were prescribed but failed to control MS. And she had frequent relapses and new lesions on MRI. At age 20, she was started on natalizumab. After 2 years of being relapse-free and having no new lesions on MRI, she actively became pregnant. See, her MRI is white. Natalizumab was stopped with the last dose at 8 to 10 weeks of gestation. During the late second trimester, that is 4.5 months after last dose, she had a relapse with significant unilateral leg weakness, requiring her to use 1% support. She was treated with IV methylprednisolone with some improvement. This was the worst severe relapse she had ever had, but it was not catastrophic. Then in her early third trimester, she had a second pregnancy relapse, that is optic neuritis, that was treated with IV methylprednisolone with complete resolution. She had a normal score and a delivery. Her baby had a normal Apgar scores, but was small for gestational age. She was resumed natalizumab within 2 weeks following delivery and remained relapse-free. She breastfed for only 3 weeks. An MRI obtained 1 month showed a dramatic increase in lesions. Resuming natalizumab as soon as possible after delivery restored her excellent disease control. A brain MRI obtained 10 months postpartum showed lasting changes and some leg weakness persisted. So this was the MRI. The first MRI was that when she had a relapse, and this is after stopping natalizumab. So what would have been the best treatment choice in this patient? The best treatment choice in this patient was not giving natalizumab. We should have given a beta depleting agents like rituximab before a pregnancy and brought the disease under control, then planned a pregnancy properly, because giving twice or thrice of methylprednisolone to the fetus during the pregnancy period is going to cause hazard to the fetus. So planning pregnancy appropriately will be the best management rather than waiting for a relapse and giving drugs accordingly. So what are the take-home messages? Women with mild disease, not on DMDs, associated with disease reactivation, may choose to stop DMDs before consumption. Less active disease Injectable therapies like latromesurtate and interferons may be continued until a post-pregnancy test or throughout pregnancy after assessing the risk-benefit ratio. So, if you want to continue injectables, a careful risk assessment reevaluation to be done. So, you have to discuss about the patient and also the time taken for the full biological effect upon DMT resumption. So, more active disease or those discontinuing therapies associated with disease reactivation, like when the patient is on drugs like fingolimab or natalizumab, use an highly effective induction therapy or interrupted dose regimes using rituximab, ocrelizumab, alemtuzumab, or cladribine before pregnancy. Bring the disease under control, wait, and then you can do a pregnancy planning. Appropriate washout period, which varies with each drug, should be done depending upon the DMT without further dosing change during pregnancy. Any questions?
Thank you, ma'am. As of now, we don't see any questions in the chat box, ma'am.
Yeah.
After the next session, we will take on the question and answers.
Okay.
Before the panel, we will do with the
Yes.
Neha.
Yeah. Thank you very much, ma'am, for that very extensive and lucrative talk for our minds. Now let us move on to the next talk on the agenda. It's an engrossing dialogue on headaches in pregnancy and puerperium by a senior neurologist, Dr. Lakshmi Narasimhan, and a senior obstetrician, Dr. Dhanalakshmi. Can we have...
Ma'am, you will have to stop sharing the screen, ma'am. Yeah. Sahiti?
Can we have Dr.
Yes, ma'am, I will share the screen.
TV, please? Dr. Lakshmi.
Am I audible, madam?
Yes, sir, you're audible.
And my slides are visible? My slides are visible?
You have not yet started sharing, sir. We'll introduce you and then you can start sharing.
Sure.
Okay. So we are very fortunate to have with us today. Dr. Lakshmi Narasimhan is the professor and HOD of neurology at Sri Ramachandra Medical College, Chennai. He has won multiple prestigious international awards such as the Palatucci Award from the American Academy of Neurology and A.B. Baker Presidential Award for Global Test Teacher in Neurology from AAN. He's also an eminent academician evidenced by the Best Teacher Award in Neurology from Dr. MGR Medical University. He's also received the Best Doctor Award and Best Scientist Award from Tamil Nadu government. We welcome you, sir. Can I have Dr. Dhanalakshmi's CV, please? Ma'am does not need any introduction. She is professor and senior consultant, Department of OG at Ramachandra Medical College. She's a very active executive committee member for OXY, and you will be able to see her in any CME organized by OXY. She's a very integral part of it. She's also an outstanding for the postgraduate and undergraduate student for almost 3 decades. We welcome you, ma'am, and let's start the dialogue session.
Sir, you can start sharing, sir.
My slide visible, madam?
Yes, sir.
Am I audible?
Yes, sir.
Yes, sir.
Yes, thank you. At the outset, my hearty thanks to the FOXY, the organizing committee of FOXY, and my special thanks to Dr. Rajeshri, Dr. Dhanalakshmi, and Dr. Jayarani. Dr. Jayarani, I know her for so many years. She was an outstanding student in her college days, and I could see bustling activity in the OXY, so especially in the safe motherhood, and I'm very glad that you have taken neurology into account. Just look at, as the doctor from Kerala, I just forgot his name, So he was telling his wife had a migraine, and Dr. Ashwath, said it could really be a nightmare, especially even though pregnancy is kind towards migraine, where almost 90% of people, their migraine attacks subside, but 10% of people who had a very stormy course during pregnancy. If you just look at this, the 59% of the headaches in pregnancy are migraine. The other three primary headaches like episodic tension type headache, clusters, and all these constitute only 5%. The hypertensive disorders of pregnancy, which includes all the eclampsia, preeclampsia, PRES, HELP, and RCVS, are all around 17%. And the pituitary adenoma or apoplexy is about 3.6. All other things are constant there. So I'm going to take you through a few of these case scenarios and then discuss with you. So the first case, a 33-year-old woman presented for preconception migraine management. She had a history of episodic migraine without aura that had been treated effectively with rizatriptan and naproxen. Preconception counseling included natural history of migraine in pregnancy, the risk, we all explained everything, and the alternative anti-migraine therapies during pregnancy. I'm sorry. She intentionally became pregnant for the first time, and once pregnant, acetaminophen and metoclopramide were prescribed for an acute attack therapy. In the first trimester, headache frequency was 1 to 2 days per week. But at 24 weeks of gestational age, she developed status migrainosus, 5 consecutive days, continuous headache, intolerable, and presented to us for follow-up. And this is the question which Professor Lakshmi has asked me. So the neurological examination is essentially normal, but because of she had never experienced such a prolonged attack previously, we slightly changed the pattern of headache. Most important thing is, if the patient says this is the worst headache of my life, or if this is completely different from the headache which I normally have, neuroimaging is a must. Non-contrast brain MRI and magnetic resonance venogram were performed were normal. A 3-day course of prednisolone because it was status migrainosus and only temporarily abated her symptoms, but again they returned. So bilateral greater occipital, auriculotemporal, supraorbital, and supratrochlear nerve blocks with lidocaine were performed with definite relief after day 1. Migraine attacks diminished in frequency thereafter and had an uncomplicated spontaneous vaginal delivery at term. You may wonder what I'm trying to talk. See, if you look at migraine, when I was an undergraduate, I thought it was a very simple disease. As I got into neurology, I understood there are about 73 types of aura in migraine. You'll be surprised. Doppelganger phenomenon, which is like you appear like a double, or out of the body experience. These are all few of the migraine auras. And sometimes you feel this is not part of your body. All these are migraine aura. And this, I just wanted to show you. This is a beautiful photograph from the Mayo Clinic where they have videographed a patient's scintillating scotoma. This is how a scintillating scotoma appears. It's a beautiful description how you can see a scotoma with the colored halos around the scrotum. So this is how the visual field looked like. So what do you do for such patients in acute treatment? The pregnancy-safe acute treatment options are diphenhydramine, peripheral nerve blocks and lidocaine, metoclopramide, prochlorperazine, promethazine, prednisone, and butalbital. Butalbital is not strongly associated with any increased risk in pregnancy. However, it is not recommended for frequent headache treatment due to risk of they tend to overuse this drug. So that's why it's not recommended, but generally it's a very safe drug. And the drugs which are to be avoided in acute migraine are the NSAID is to be avoided between 12 to 20 weeks. Indomethacin should be avoided. And even we don't give acetaminophen or ergots or lasmicidone, or most of the G-PANs, which are the new generation of drugs used in migraine, we avoid them for acute treatment. So acute treatment, I've given these are the drugs. Here, you understand that the peripheral nerve blocks with lidocaine is what we used for the patient, the case vignette which I said. That whole world is now moving towards the either nerve blocks or the gadgets in migraine. So these are the neuromodulation devices which are used in migraine. Cephali, which is FDA cleared for acute and preventive migraine. Spring TMS, FDA cleared, single pulse transcranial magnetic stimulation. Gamma Core, which is again FDA approved device. Nerivio is what we use in Ramachandra. We have started using this Nerivio for our patients. FDA cleared acute treatment for episodic migraine. Relivion is, we don't have it here, but even though these are the few devices, so you will now understand that there is a drastic change between pharmacotherapy towards non-pharmacological therapy in the form of various gadgets using either a transcranial magnetic stimulation or non-invasive preauricular vagus stimulation or an electrical stimulation. So afferent modulation of the neurological circuits is going to be the future. So peripheral nerve blocks, which I have already talked to you for the case vignette which I have shown, greater occipital, we use, most important thing you should remember is lidocaine is preferred than bupivacaine. The peripheral nerve blocks are performed in greater occipital, auriculotemporal, supraorbital, supratrochlear nerves with local anesthetics. And what about the preventive treatment? The pregnancy-safe preventive treatment options are cyproheptadine, verapamil, memantine, coenzyme Q, and riboflavin, and all other drugs which normally used for prevention, like various AEDs, the G-PANs, the pregabalin, butterbur, all these things are not safe. Even most of these drugs which I am quoting are all only the class B recommendation on evidences, and none of them are class A or type 1 class 1 evidences are not there. Magnesium, a word about magnesium is may prevent the wave of brain signaling. As you know that the cortical wave of depression is the starting point of the migraine attack. Magnesium prevents that, and American Headache Society of American Neurology is given a level B rating for migraine preventing therapy using Maxself. The second case is a 23-year-old woman. But I should first thank Professor Dhanlakshmi because she gave me all the scenarios. And whatever scenarios which I'm talking is what she gave her. And based on that, she wanted to have one pre-migraine patients getting into pregnant, one secondary headache during this. So she sequenced every scenario and then made my job pretty easy. My sincere thanks to her. A 23-year-old woman in her first pregnancy.
Can I read it for you, sir? Can I read it for you? Can I read it for you, sir?
Yeah, please, madam. I'll be happy.
Yeah. So this is another second pregnant lady who is just 23 years old, and she's got a sudden onset of severe headache, just 3 days duration, a fixed at bifrontal location. Her history included rare attacks of migraine without aura during her teenage years, but her current symptoms are nowhere similar or of a remote migraine attack. She feels like they are different. She described a perturbation of her binocular peripheral vision that was not demonstrable on neurological examination. And of course, she underwent fundoscopy, visual field testing, and pupillary reflexes. Everything appeared normal. We sent her to ophthalm department, and everything appeared normal. But she feels this headache is different from the headache which she used to have in the earlier days. Next slide, please, sir. So how do you approach this patient? She's very clear in her way she comes to you. Her headache has changed its pattern. Yes. So what solution will you give her, sir?
Thank you. And this is a clear depiction. This girl had migraine in her remote childhood days. After that, she never had. But this time, whatever she came was acute headache and subjective visual blurring. So the visual testing by confrontation method didn't yield anything. But any change of pattern, immediate requirement is a neuroimaging. The preferable neuroimaging in pregnancy is MRI. I will come back to that. Madam has asked me that question also. So I will be addressing that issue a little later after the few of these case vignettes. So MRI revealed an expanded cella with a fluid level. You can see a very clear fluid level and the optic chiasm getting compressed. This is a classical case of pituitary apoplexy. Though the confrontation didn't yield anything, the automated perimetry revealed the bitemporal hemianopsia and the prolactin levels were very high, 395. And because of the visual loss, we immediately planned for a transsphenoidal resection, which is through the nose. Don't have to open the skull. It's a base of skull-based surgery through the transsphenoidal route, along with the both. It's an overlapping field, but both the skull-based neurosurgeons and the ENT people, or sometimes they do together. She was completely the tumor was excised, prescribed levothyroxine and peripartum hydrocortisone, and otherwise had an uncomplicated vaginal delivery. So, whenever you can see on your right hand side of the screen, whenever this you can see here, do all the hormone profile, do an MRI or CT for cella, diagnosis confirmed, decreasing level of consciousness, severely reduced visual field, go for surgical management. If both of them are not there, go for a conservative management, close monitoring of the neurological and visual endocrine and endocrine evaluation every 4 to 8 weeks, and repeat MRI at 3 to 6 weeks, and annual biochemical assessment of pituitary function, annual MRI first 5 years to it. So this is exactly the algorithm which you follow in a pituitary apoplexis. We should not miss this because it will result in sudden loss of vision and acute severe headache, new pattern. Should not miss. This constitutes about 3% of the Yes, madam.
This is another patient who presented at 28 weeks of gestation with the sudden onset of severe headache and typical neck pain and recurrent vomiting episodes. And we went into the past history that was not significant, or throughout her 28 weeks, she never had any complaints. So, on examination, next slide, sir. So, how would you like to approach the case?
Yes, madam. So, what happened? This is a case, your patient had a nuchal pain, headache, vomiting, suggestive of a meningitis or a close differential is a subarachnoid hemorrhage. The MRI, again, we did an MRI. MRI showed subarachnoid hemorrhage. After presenting the digital subtraction angiography, revealed an aneurysm of the left posterior cerebral artery with neck of 2.9. The coiling of the left PCA dissecting aneurysm, under the pseudolobule is done. Control angiogram showed complete occlusion of you can see that this is the aneurysm, which is, you can see the DSA has disappeared. So, whenever you see a aneurysmal subarachnoid hemorrhage, now, in fact, most of even the DSA and all exposure, there are fairly safe techniques are available to avoid radiations to the fetus, and the coiling can be done safely during pregnancy. Discharged on the 6th postoperative with mild residual headache, normal motor function without any cranial nerve deficit. Medicines continued after discharge with levetristam, which is safe during pregnancy, and nimodipine for 6th hourly for a few days, which to be avoided for the vasospasm. Whenever you meddle the arteries, you can develop a vasospasm, resulting in deficit. To prevent the vasospasm, you use nimodipine, which is apparently a calcium channel blocker, which can be used during the 3rd trimester. Madam?
Yes, this is our case which came at 37 plus weeks, emergency room with a sudden and severe headache, which just ascended in seconds. And she also experienced nausea and vomiting when taking a shower. And she does not give any history of migraine in the past. But history resembled as
any headache which reaches its peaks in seconds, we call them as thunderclap headache.
Thunderclaps.
So the pregnancy had been uneventful. There's no medication. All these things were similar. No, at least until this visit, nothing was there. In the emergency room, she was conscious, showed no signs of neurological deficit, including sensory impairments or paralysis. She was afebrile. Blood pressure was 168/82. The rest of the physical examination was normal. But MRI showed high intensity areas in the bilateral basal nuclei. You must have seen the flare sequences. You see the high intensity lesions in the left occipital white matter with some blurring. This is, they look like a press. It also was detected in the flare sequences. The MR venography of the dural venous is unremarkable. Then the MR angiography without contrast agents revealed arterial segment narrowing corresponding to vasoconstriction, and bilateral middle cerebral arteries MCA, PCA, and ACA were all showed constrictions. No cerebral aneurysm was detected. This is the classical presentation of the reversible cerebral vasoconstriction. What I want to tell you is this RCVS can coexist with PRESS. PRESS is nothing but a loss of autonomic control from the vascular endothelium in the brain during pregnancy. Not only pregnancy, during it's one of the hypertensive disorders of pregnancy. There are situations in non-hypertensives also it can happen, and not necessarily there are extra. The PRESS can happen. There are even nowadays they're talking about spinal PRESS, brainstem PRESS, cortical, usually predominantly in the occipital cortex. The PCA is the most commonest artery which is available. And this another disease entity which is the RCVS, where you can see the constrictions of the blood vessels in the bleeded appearance of this. And this is you can see the vessels are. You just have a look at this, have a mental picture of this, and see the DSA after the vasospasm is gone. You can see all the vessels have opened up in 3 weeks. So this is a classical case of reversible cerebral vasoconstriction syndrome, RCVS. Nothing extraordinary need to be done. Only thing, you must be aware of this condition, treat it symptomatically and take care. And with follow-up imaging, they will go out. And madam asked me, you should also give a note on what are the contrast agents during how to. So all the 3 cases I have showed MRA. So, and except for one case, the DSA where CT. So I will just the potential indications in pregnancy for X-rays. The CT nowadays low dose CTs are available. There are few, especially for pulmonary embolism, suspected pulmonary embolism, or in certain cases of trauma where CT is essential. It's being done, or situations where MRI is contraindicated. So even though the fetal malformation, growth resection, and all, you have to apply the benefit risk ratio and then go ahead. IV contrast, iodinated contrast, not routinely used, but can be considered at any time during the pregnancy because harm to the fetus, a theoretical risk for neonatal hypothyroidism. So always keep the dose as low as possible. And the risk of the childhood cancer detection is 1 in 10,000 to 1 in 1 lakh and can be justified when clinically indicated. The iodinated contrast in pregnancy, oral contrast are absolutely not contraindicated. Do not cause any theoretically no harm. Whereas IV iodinated contrast, which is used in CT, can produce fetal thyroid abnormalities, and recommended the contrast only use is absolutely required. So this is about the CT. If judiciously used, oral contrast or iodinated contrast, no issues. IV iodinated contrast with extreme precautions on situations where MRI is contraindicated. Lactation, breastfeeding can be continued without any interruption after the use of iodinated contrast. Coming to MRI, MRI, even fetal MRIs are available. So essentially, there is no issues, brain imaging and fetal imaging. But there are certain things in the first trimester you have to be very careful and very judicious. The contrast, another biggest advantage of MRI is MRA and MRV do not require a contrast. They all based on time of flight sequences, which depends upon the flow of blood. So you don't require a contrast at all in routine. MRA and MRV do not require a contrast. So you can safely go ahead with doing it. This is the biggest advantage in pregnancy. Coming to the IV contrast use of gadolinium base, it crosses the placental barrier, shows MRA contrast use in pregnancy associated with a broad set of complications. The recommendations is considered safe in pregnancy. Even the US, most of the regulatory says that except for the first caution in the first trimester, other trimesters, it's fairly safe. So this is about the MRI. And there are 2 kinds of contrast available for MRI. One is gadolinium based, and the second is a super paramagnetic ion. For the super paramagnetic ion process, there's no studies are available, no evidence is available. Gadolinium contrast during pregnancy is controversial, but still, if needed, we can use it judiciously. And this is what we use. even though the duration of fetal exposure is not known, the contrast present in the amniotic fluid or re-enters, we don't know, but it is used. Lactation, breastfeed need not be interrupted after gadolinium administration. So I have told you about CT. MRI is fairly safe. MRI, when required, the situations requiring a contrast MRI itself is very less, unless most of the information is given by a non-contrast MRI and MRV itself. The contrast requiring situations are very, very less. And even though it is being used, it can be judiciously used, and breastfeeding need not be stopped. So this is what so I have already told you, super paramagnetic contrast, there are no information is needed. Yes, madam.
This patient presents at 22 weeks. She's a primary gravida. Headache and blurring of vision. Her blood pressure is 130/90. And she's got a bilateral papilledema with a visual field constriction and decreased acuity in both eyes, 6/12. There was no neurological deficit, only a visual symptoms alone. Her BMI is little on the obese side, 34.6. So how do you approach this patient, sir?
Thank you. This is so what is essentially is, again, if you look at this, she's very obese. You can see the BMI is about 34, and the moment, and she's a twin pregnancy, and visual blurring, headache, visual blurring, obesity. First thing we think about is idiopathic intracranial hypertension. So we did the MRI. MRI showed flattening of the posterior sclera, partial empty cella, and the tortuosity of the optic nerve suggestive of that. So CSF manometry was done, 25 centimeters of water, which is high. And headache and visual symptoms improved after CSF drainage with 40-30 ml therapeutic lumbar punctures. And the visual field became normal. The papilledema still persisted. You can see this is what you can see. The optic nerves are redundant here, and you can see the posterior, instead of the globe, it is flattening of the sclera, which I am showing. I don't know whether you are able to see my.
No, we are able to see, sir.
Okay, fine. And you can see that cella is filled with water, and so these are all the classical features of the idiopathic intracranial hypertension. She experienced the preterm labor, 35 weeks, underwent cesarean section under general anesthesia to prevent the consequences of further rise in intracranial tension during uterine contractions. Postoperative period was uneventful, returned follow-up after 1 year, at which time she was asymptomatic and ocular fundae where everything is normal. So IH, the drugs which we use are acetazolamide and topiramate. So essentially, the recommendation use optical coherence OCT, monitor the papilledema, and track the activity. And whenever the use of most of this, both the drugs are fairly not much recommended during pregnancy, but what we do is we manage them with I told you about the therapeutic lumbar drainage. And weight reduction is what is most important, serial LP and surgical management. And sometimes when impending visual loss, we go in for either an optic nerve fenestration or a VP shunting or a dual sinus stenting. So the delivery, especially what happens in IH patient, the prolonged second stage of labor, consequent to Valsalva, it can exacerbate the loss of vision. So normally the mode of delivery is, even though the obstetric factors, we generally recommend a cesarean to avoid the uterine contraction can also further increase the intracranial pressure. Madam?
So with respect to the previous case, I had one patient who came for hysterectomy at 47 years. She had forgotten this history of shunting, which was done during her pregnancy for a raise, probably a raised intracranial tension at that time. So when we opened up the abdomen, we could see some wire coming out. Then she was under regional anesthesia, so I took the history at that time. That time only she revealed like she had a hypertension during her earlier pregnancy. The son was grown up almost 22 years old, and then she slowly recollected that there is a tube which goes from the brain to the stomach area. So that is what she told. And
the VP shunting, the VP shunting, they would have done it. The ventriculoperitoneal shunt, you would have seen the tube. Which is
she forgot about that incident completely. So
most of the people, madam, because sometimes what happens about a few of the children who have impending loss of vision, the IH, obese children, 13, 14 years, they would have forgotten about the entire episode of the VP shunting itself. And they may not remember.
Yes. Okay, now coming to the sixth scenario, I think we have one more scenario, sir. She was admitted This patient was admitted to the hospital with headache and neck pain. She developed 2 hours after delivery with uneventful epidural analgesia 6 days before. And oral medication with paracetamol. Generally, we give only a dose 650 or IV infusion paracetamol. The patient reported a postural frontal occipital headache. With the severity scale, it worked out to 8 on 10 with relief by lying down flat. She also complains of tinnitus as an accompanying symptom. There was no history of a primary headache before this episode, before she delivered with an epidural analgesia. So what is the solution for her?
Yeah, this is the most important point in this case scenario is the postural headache. Whenever somebody talks about, you can see the postural fronto-occipital headache, whenever somebody and tinnitus. These two are very, very important. They suggest that there is, patient had an epidural catheter, and all these things suggest that there is a CSF leak. CSF leak producing spontaneous intracranial hypotension produces a classical postural headache. And one of the important catchy symptom is the tinnitus. So neurological examination showed mild meningeal signs with no focal deficit. MRI with the time of flight angiography, MRV, and gadolinium was performed to exclude CVT. You can see the patchy meningeal enhancement. This will always be confused with meningitis. You understand, whenever the intracranial hypotension happens, a lot of changes happens in the intradural compartment. What happened? The hemodynamic changes first get reflected in the intradural compartment. So the meninges become very highly enhanced. There's a patchy meningeal enhancement. I will show you the picture. You understand. You can see that there is a gross meningeal enhancement, and you can see that there is a sagging of the brain, and these two, and sometimes it is so much that you can develop a subdural hematomas. Bilateral subdural hematomas can also develop. Not only the meninges become thick, and they can also develop a subdural fluid collection. So these are all the classical features of this, and we treat them with either xanthine or, most importantly, the pressure is so low, they can sag, they can become comatose, the medulla descends down, and then foramen magnum herniation, and they become comatose. In fact, when sometimes you'll be scared, madam, after post-delivery, we have at least had 2-3 cases where we have to immediately give an autologous blood patch, epidural blood patch to save the patient, and the response is dramatic. We give an epidural blood patch during the called gold standard treatment for post-dural puncture headache, and you'll be surprised. There will be pinpoint pupil, patient be unconscious, and the coning starts. So, and it is highly reversible. You must be, only thing you have to be aware of this entity. Look for this entity, postural headache, tinnitus, and patients few hours after the delivery, postpartum. You have to be very, very careful. Thank you.
So,
this is the last case.
I had a personal experience of postspinal headache, and luckily I did not have any of the symptoms. I never went to a MRI at that time. It was 25 years back. Now coming to this last we met, which is she's a para to life to postpartum, and she has received a epidural analgesia as is a practice in our institute to offer them whenever they ask for it, and it was noted to be difficult with 4 attempts. The new anesthetist took some time to introduce the epidural catheter. Immediately post epidural, she complained of severe continuous frontal headache, neck stiffness, which was initially thought to be due to muscle spasm. But she lacked the traditional characteristic of a post-dural puncture headache, including positional components of pain. Like it was not changing with position. She was made to lie down flat, and nothing was changing her headache pattern. How do you approach this patient? She returned on the postpartum day 10.
Postpartum day 10, but still having headache. So the post-dural puncture will be beyond a week when you don't entertain the diagnosis of the dural puncture headache anymore. And so patient also had neck pain and low-grade fever with 1 episode of GTCS. So the moment the patient has a convulsion, neuroimaging is a must, and neuroimaging showed, and this is what the neuroimaging, you can see there's a filling defect in the superior sagittal sinus extending into the tacula, or the proximal transverse sinus, it's consistent with cerebral venous thrombosis. And this is the most commonest thing which we both, the obstetricians and neurologists, think, even though it's most common, even now it is still challenging because the pregnancy is a hypercoagulable state and persist in the puerperium, and the specific pathophysiological observations, anemia, outlet platelet function, lot of prothrombotic substances from the placenta initially from the placenta. Sometimes the hormonal changes, all these things can predispose. The greatest risk is in the third trimester, in the first 4 weeks of postpartum. And the classical symptoms are headache, double vision, blurred vision, and altered consciousness. Word of caution is whenever the patient's deep venous system gets involved, the patient's arousal, because the midline structure, you see a butterfly shadow in the thalamic area, and the consciousness slowly goes down when both the dural venous sinuses and the deep venous system gets involved. As long as the deep venous system is not involved, very easy to treat a cerebral venous thrombosis because there's an alternate channel to take the blood out. The moment the deep venous system is involved, or the internal jugular veins on either side, they're getting involved, it's going to be difficult. And the diagnostic imaging, as I told you, is MR venography, and it can show the venous infarcts or the hemorrhagic infarcts, bilateral, not fitting into any arterial territory, or can have a subarachnoid bleed. All these things are characteristic features of that. I can show you a few of them. You can see an hyperintense sigmoid sinus, where the sigmoid sinus turns into the jugular vein. That is the area where it's near the trend. We'll show the hyperintensity, and then you can see a T2-weighted intense band of venous infarct on the frontal lobe. You can see the blooming in the susceptibility. This is how the blood looks in susceptible SWI sequence in MRI. And in MR venography, you can see the absence of the right transverse sinus, sigmoid sinus, and the internal jugular vein. And the venogram shows, you can see the empty delta. What is important is, the arterial blood flow is laminar flow, whereas the venous flow is axial flow. So the arterial thrombus occupies the eccentric, attached to the vessel wall, and it's eccentric, and the flow is in the periphery, whereas the venous thrombus is axial. And that is why when you give a contrast, the filling defect is in the central. It's like in delta and surrounded all around by the contrast. And that is why it's called an empty delta sign in the periphery. And vitamin K antagonists are contraindicated. We don't give because of the risk to the fetal cerebellum. Newer oral anticoagulants, a lot of trials are happening. Use of oral pregnant in women trying to conceive is currently contraindicated, even though there are 4 newer oral anticoagulants: dabigatran, devaroxaban, apixaban, hydroxaban. And they are right now puerperial, we can use it, but for pregnant, it is contraindicated. And low molecular weight heparin is the drug of choice for even though there is no one-to-one trial. The trials are there for pulmonary embolism, the physician's guidelines and the chest physician guidelines, and we have adapted that even though we don't have much data. And this is very important. For the woman with cerebral venous thrombosis during pregnancy, low molecular weight heparin is a full anticoagulant doses should be continued throughout pregnancy. And low molecular weight heparin or vitamin K antagonist, the target of INR should be continued for at least 6 weeks postpartum. Class 1 evidence. Advise these women with a history of CVT for future pregnancy. It is reasonable to advise women with a history of CVT that future pregnancy is not contraindicated. They can go ahead. Only thing is, need a hematologist, team of hematologists in maternal fetal medicine. Able to treat acute CVT during pregnancy with full dose of low molecular weight rather than ultra-fractionated heparin. The women with a history of CVT, prophylaxis with low molecular weight during future pregnancies and postpartum period is probably recommended. It's class 2A. So these are the American Stroke Association recommendations. One point worth to remember is few of the low molecular weight heparin have a excipient as alcohol. So you must be very careful in choosing which of the low molecular weight which you are going to use. Second important point, one lady is still remember antiphospholipid with a CVT, one gynecologist, husband is an orthopedician. Post-delivery, she had a severe back pain, and The orthopedician thought it is functional. She's not going to the clinic in spite of this, and the problem was heparin-induced osteoporosis, severe osteoporosis and heparin-induced osteoporotic fractures. You should not forget, somebody who has taken heparin throughout the pregnancy can develop osteoporotic fractures post-pregnancy or puerperium. Please do not treat them as functional. Thank you for your attention.
Thank you so much, sir, for
And
developing
you
on the
would agree with me that Madam has chosen excellent case scenarios, so that are very, very practical. She made my job very easy. And my sincere thanks to you for the lovely case scenarios which you have told me. Thank you.
Thank you, sir.
So there's just one question in the chat box, question answer.
Yes,
is there any absolute contraindication for hormone use for aneurysms of brain?
Not for aneurysms. We generally are very, we have seen the hormone use, even in a few days, those who are vulnerable, they develop venous thrombosis. That's far more. And secondly, even in aneurysm, they form a thrombus. I don't know. The estrogen, most of the female hormones are, the cerebral vasculature is very sensitive. You must have seen all your experienced gynecologists would have seen all throughout your life. I don't know, but there is a few subset of people who develop such complications very frequently. I really don't know what are the other factors which play in, but even one strip of oral contraceptives for the regulation of menstruation, they come back with papilledema. Whereas there are people who have taken for years together, then nothing happens. I really do not know what are those factors which happen. But one thing is sure, the cerebral vasculature is very sensitive to the female sex hormones. So one has to be very, very careful and judicious unless are definitely indicated. And you keep a watch on the cerebral vasculature all the time when you put on the hormones.
My patient landed up on the second day of oral contraceptives. Just overall started for regularization of a cycle. Second pill,
yes,
she was at the neuro.
Madam, this subset of people, they are very quick to develop a complication. I don't know. In fact, I was thinking that I should look into which subset of these people are vulnerable for this. I'm planning to look into the data about that.
Thank you so much, sir.
Nice to see all of you, madam.
For developing on the request for.
Thank you, Professor Jairani, for giving me this opportunity. Thank you.
Thank you, sir. Thank you. Nice to see you after a long time. And it's a very amazing way you would have presented very nicely, and I really appreciate Madam for giving nice case scenarios for very practically. Very much you touched very practical points, and it's really very nice and wonderful to hear from you. Thank you so much for joining with us for this interesting discussion. Thank you.
You'll have to stay back.
Yes, sir. You're going to stay back anyway. We'll continue.
Sure.
Sneha, yeah.
Thank you so much, ma'am and sir, for providing us with so many myriads of interesting clinical cases. It was really absorbing dialogue, and I think we're going home with a lot of practical take-home points. So if there are no more question answers, then let us go on to the second half of today's CME, which is going to be a panel discussion on non-eclamptic seizures in pregnancy. For this, I'm very happy to introduce the moderator for today's session, Dr. Usha Vishwanathan, who is the professor and HOD of Department of OBGYN at Ramachandra Medical College. She has outstanding credits to her name, and she's the sole author of textbook of OBS for undergraduate and postgraduate by the renowned publisher Elsevier. And she's also designed mobile app called Suraksh for intrapartum monitoring of patients. And she's the head of quality and patient safety at Ramachandra Medical College. We welcome you, ma'am.
Thank you.
In our set of distinguished panelists, first I would like to introduce Dr. Jaya Vijayaraghavan, ma'am. She's the Emeritus Professor and Senior Consultant, Department of OBGYN at Ramachandra Medical College. She's an adept and proficient academician and a practitioner. She's guided many undergraduate and postgraduate students in several aspects of their academic training. She has also been invited as faculty to many conferences and also conducted the international research of Pearl 1 study. Welcome you, ma'am. I'd like to introduce Dr. Sunita Samal. She's consultant OBGYN at Apollo Hospital at Thousand Lights. She held the post of HOD at SRM Katangulathur and professor at Mahatma Gandhi Medical College at Pondicherry in the past. And she's an eminent teacher and has multiple publications to her name in various national and international journals. And she's won multiple prestigious awards and organized various CMEs. Welcome you, ma'am.
Thank you.
Dr. Lakshmi Narasimhan and Dr. Tamil Pave, we just introduced for the previous stars. Welcome you, sir and ma'am, for the panel. I hand over to Dr. Usha, ma'am.
Thank you. Thank you, Sneha. Are you able to view?
Yes, ma'am.
Okay.
Yeah, ma'am.
Okay, I am very happy to be in this panel. It's very evenly balanced. We have two obstetricians and we have two neurologists. So let me just go ahead. Non-eclampsia seizures in pregnancy. This question probably I would ask one of the obstetricians. There's a 30-year young pregnant woman. I wouldn't call any woman old, okay? So all of them will be 30-year, 50-year young only. So 30-year young pregnant woman comes to the emergency with seizures at 24 weeks with a blood pressure of 110/70 millimeters of mercury. No history, anything suggestive of a possible hypertensive disorder in pregnancy. So how would you evaluate this patient?
First of all, I would like to take the history of the type of seizure she has had. And secondly, I would like to know whether she has had a past history of seizures.
Okay.
And in our country where there are certain taboos, they may not have revealed the fact that they were epileptic. And once they become pregnant, they would have stopped their anti-epileptic drugs. This is a very important thing. And sometimes you may have to take the patient into confidence, send the relatives away and take this history. So that is one thing which you need to do. And whether, of course, there are other aspects for seizures in pregnancy. This patient does not have, whether she has had history of fever, whether she had any trauma. And those are the other things we need to look into. And whether she has had there is no this thing about her previous pregnancy. So if she has had a previous pregnancy, how was it? What was it about? How was her postpartum period? Did she have any convulsions during that time? These are the certain things we should look into. After taking the history, we would like to see the patient and see her physical examination to see whether she has any neurological deficit. Look into the obstetric examination of the patient also to see how the baby is, whether you can hear the fetal heart. And there could be events of bradycardia even following a seizure. So these are all normal and we should not jump into the conclusion to terminate the pregnancy.
Thank you, ma'am. All I wanted to say was this is how we teach students, any pregnant woman with seizures, to think of eclampsia unless proved otherwise. But when eclampsia is ruled out, what do you think will be the next most possible diagnosis that you would have? You said epilepsy. So, and very truly, they may not reveal the history because of various taboos. Okay. Dr. Sunita, ma'am, what is the preconception education you would give the family of an epileptic woman who wishes to conceive?
Yeah. So when the anti-epileptic, she will be definitely on anti-epileptic medications. So in the preconception, it is very important what type of anti-epileptic drugs she is taking, whether she is taking a single drug or a multiple drug, and because there is chance of congenital anomalies are there depending upon the type of drug, dose of the drug, and also whether it is a monotherapy or a polytherapy. So you have to explain the patient regarding, and also what type of seizures she had. And suppose he had a convulsion within 1 year of before planning for pregnancy, then there is a high chance he can have a seizure disorder during the pregnancy and the delivery also. And those who are having for long time, they don't have a seizures more than 10 years and all. In those cases, they are very unlikely to have seizure during pregnancy. So very high risk is those patients who have a recent seizure just before the preconception period. And we have to tell them once they're planning for pregnancy, means the dose they have to consult a neurologist and the obstetrician both together, a multidisciplinary team. And depending upon that, you have to plan for the lowest dose possible where the convulsion like the seizure can be controlled, and we should plan give a monotherapy rather than give away multiple drugs. And also we have to choose a medication where the congenital anomaly is the least. Like you will see the sodium valproate, there the chances of anomalies are more congenital anomaly as compared to the other medications. So we have to preconceptionally patients should consult a neurologist and the obstetrician which medications he should take and what are the doses, and also what are the like you have to counsel the patient what are the complication can arise.
Okay. Okay. I just want to ask a question to the neurologist, any one of them. Sir and ma'am, would you give any time frame beyond which you say, okay, 6 months you have been free from seizures, you can now conceive, or 1 year? Is there any time frame that you would think of? Any one of you can take the question.
Madam, it depends upon the type of seizures. Any family history is there, any abnormalities on neuroimaging. Based on that, we just decide the duration of course of the epilepsy, how long the patient has been an epileptic, and families and so many risk factors have to be taken into consideration before stopping an anti-epileptic drug.
Okay. So there are multiple things that you would actually weigh before you are deciding, and not just
I
the
just
time.
want to add.
Yes,
want
sir.
to add one.
Yes, sir.
There are a lot of studies that if you have a seizure control 9 months prior to conception,
okay,
the chances of uneventful pregnancy is very high.
Okay.
So, as a neurologist, on the reproductive, any girl at the reproductive age group nearing her menarche, I will ensure that just the 9 months, 6 to 9 months prior to her becoming pregnant are very crucial. If I'm able to control the seizures with drugs, appropriate drugs, which she can continue during pregnancy in those 9 crucial months, the likelihood of, you'd be surprised the percentage of uneventful pregnancy if you have a preconceptual period control in 9 months is good. The uneventful pregnancy rate is very high, more than 70.
Very good.
A lot of studies are there. You can see. That's why the cutoff, the question which you asked, I thought I'll take it as 6 to 9 months.
Thank you. So we need some ready reckoners like this, because when we talk to the patients, we can also tell them that according to studies, for 9 months, if not had, we will also get some. Thank you very much for that. Does the frequency of seizures increase during pregnancy, and the treatment guidelines, let's say generalized tonic-clonic seizures, is there anything that triggers increase of seizures during pregnancy in spite of being treated with drugs? And I think I'll stick only to that part of the question here.
Yeah. So actually in pregnancy, the seizures actually doesn't increases during the pregnancy. Almost you will see 2/3 of the patient, they don't have seizures. Like the risk only for 1/3 of the patient they can have. And the treatment guidelines also it depends upon compared to the postpartum and the intrapartum period, there the chance of seizures is more as compared to the antenatal period. But as such, the risk of seizures during pregnancy is not much.
The theoretical, this thing is about 70% of them remain stable.
Yeah.
And about 15% increase and about 15% reduce. That is a bare figure which I could
and there are some risk factors
memorize. But however, there are some pharmacokinetic changes which occur in the drugs.
Yes.
So those need to be, and particularly the newer drugs which I'm not very well versed with, they are the ones whose pharmacokinetic, the drug levels have to be done during pregnancy. So
yeah,
these are certain aspects which we need to understand when we are having a pregnant patient with drugs in pregnancy. Of course, you do have to change into monotherapy, and all those things are well known, but you need to this.
You want to add anything to this, sir, or Dr. Pawai?
Even though as Madam rightly said, the 1/3 rule always applies in the rule of nature. See, 1/3 of the people, 2/3 they remain stable. 1/3 people who are either an increase or decrease, as Madam has rightly put it. reasons are multifactorial. And as she rightly put, the double circulation, which the maternal thing, the lot of hemodynamic changes which happen, and that result in the pharmacokinetic changes on the drugs, both the pharmacokinetic and the pharmacodynamics of the drug availability, and the drug losing its therapeutic window is fairly high during pregnancy. And puerperium, as Madam rightly said, especially for child rearing, they have to be wake up. Sleep deprivation is a very strong trigger. So generally, definitely the frequency increases during puerperium. But during pregnancy, by God's grace, it will try for unformed sleep production is protected.
Even in late pregnancy, you have sleep deprivation, sir. She's not able to sit up. She's not able to sleep. So even late pregnancy to puerperium, I would say, and lactation.
Yeah, that's what I'm saying. The sleep deprivation plays a very major role in triggering a seizure in pregnancy.
Yeah, this question is, most obstetricians are faced with these questions. Can I take this drug? The neurologist has given these drugs and they say that you must be taking these drugs. So what is the risk of congenital malformations with the current prescription of anti-epileptic drugs?
Yeah, we all know that carbamazepine, which is the most commonly prescribed, does have its own set of neural tube defects and cardiac defects, but which is not very high, 2 to 3%, but for the patient, it is 100%. With regard to the newer drugs, they say lamotrigine is safe, but I have no experience on it, and we can ask the neurologist to highlight on that. But definitely no for valproate, no, and it has to be changed prior to pregnancy because it works through multiple channels. So therefore, the chance of congenital aneurysm is very high with valproate. Oxycarbamazepine and the other ones are not much data, but I'm not the person to comment on them.
Yeah, and it's probably that teratogenicity period, the organogenesis period is the time that we are so particular what are the drugs that the woman actually is taking. And after that, when she moves on to the second and third trimesters, most drugs are taken. Any thought on this, Dr. Pave or sir? Congenital malformations.
Most of the pregnancy registries, the Europe Pregnancy Registry or the North American Pregnancy Registry, the Indian Pregnancy Registry of the Kerala Epilepsy Group, all have revealed that among the newer AIDs, levetrestam is very, very safe. Levetrestam has been the least among all the congenital malformations. Second thing, it's very safe in comorbid liver or renal. You don't require any dose changes. And its interactions with the other drugs is very, very minimal. So now, in fact, it has, I would say it has beaten carbamazepine to lead the top as far as the drug of choice in women with for wanted to have a safe pregnancy. Second thing is, as Madam said, for everyone, it's for the patient is 100%. Whatever percentage we talk about for the patient is 100%. One important thing we should understand is overall, the patients are not taking any AEDs. The overall percentage of somebody getting a congenital malformation is 1.5 to 2%.
Yes.
General population.
So about around 2 per 1,000.
General population, yes.
General population. So here becomes 4 to 4.5, except on a high dose valproate, which takes it to about 6 and 7. All other things, it's all hovers around 4 to 5 only. Most of these drugs are between 4 to 6 max. Lamotrigine, which came as in fact, it is called as a drug for the female. It is but the only biggest problem is to maintain a drug level. So much of fluctuations during antenatal period. It is highly difficult to maintain the drug. And secondly, it takes so much time to kickstart. You start low dosage. By the time you reach the therapeutic dose, you'll be too late. And third thing is the rash, lamotrigine rash, dreaded. And so we are comfortable with levetrestam. I don't know, I think Professor Thampavi would agree with me. Most of us use levetrestam as a drug next to carbamazepine.
Yes, that's what yes, I agree with
another problem with this anti-epileptic, initially they cause congenital anomalies and later some of them even cause neurocognitive problems in the children.
The cognitive impairment is what more we are concerned. That is maximum with valproate. More than the organogenesis, the follow-up of the IQ impairments post the children is exposed to anti-epileptic drugs in utero, resulting in cognitive decline is far more because of the recession of a lot of synaptic things. So that's also we are concerned.
Okay. I just want to add one more thing. Like, suppose the lady had, like, in the first pregnancy, the baby has a congenital anomaly because of this anti-epileptic drugs. So, in the second pregnancy, the chance almost increases up to 10 to 15% of having an anomaly.
Yes.
Okay.
Yes, madam. It increases.
Okay. So we have safe drugs. I mean, yes, sir. So put it fine. Yes, sir. So to put say it finally,
bottom line is levetiracetam and carbamazepine.
Yes. So we have drugs which are pretty safe in pregnancy. Guidelines for antenatal care for women with epilepsy, Jaya ma'am. Do you think it's any different from others, or is there anything that you need to focus on for these patients?
For a patient who is fairly stable, like I think a neurological consultation in the initial part of the antenatal care and one prior to delivery, I think would suffice. But for patients who are not stable, who continue to have fits during pregnancy, I think a consult along with the neurologist is what we should aim at. And at least once a month or even more frequently if they develop further seizures during pregnancy.
Otherwise, I think the rest of the antenatal care is in line with most high-risk women. Okay.
Drug monitoring the drug levels adds another important area during. That's one added thing which we don't do for the other.
Yes.
Probably the drug level monitoring. And one thing is for especially the antenatal scans overreacting to certain parameters, and there's a lot of intra observer variations are present in the measurements of the nuchal cord, the nuchal length and all the various neural tube abnormalities. Identifying and treating in at least creating an anxiety panic to the parents. The ultrasonographers have to be very careful. They have to be very judicious before making because they become so apprehensive. They live in anxiety until the delivery, even though we tell them that this is nothing. For example, even the chorionic plexus, which transiently appears and disappears in an ultrasound, and some wrong things are given to them, and it's very difficult for us to make her anxiety levels less. She lives until she delivers. Very, very difficult. They live in anxiety, and that anxiety causes a lot of harm to the child. So I wish all the sonographers have to increase their level of expertise and their knowledge before predicting anything before telling anything to the parents.
Yes, sir.
And this reduces the compliance of the drugs also. They will not take the drugs for the fear of.
You're true.
Yeah.
Okay. So how does Dr. Sunita, the intrapartum and postpartum management of epileptic women, intrapartum especially?
Yeah, so intrapartum, suppose the patient is already on anti-epileptic drugs, he has to continue the medication. If not possible oral, then
we change it to intravenous.
Intravenous, yeah. We change it to intravenous, particularly those patients who are high risk for development of seizures. Maybe as we told, like within 1 year of before conception, she had seizures, or in between pregnancy also she had seizures. In that case, we should maintain the IV, and there is no need of doing a continuous, it is as usual as the routine pregnancy for a continuous electronic capital heart rate monitoring. It is not for epilepsy, it is not needed. Suppose the patient had a seizure during the intrapartum period, so then there it is mandatory to have a continuous CTG for the monitoring of the fetal heart rate. And there is no indication of any induction because of epilepsy or a indication of cesarean section. It is all related to the obstetrical regions. We can go for either cesarean section or a induction of labor. And in the postpartum, the requirement of the dose, usually the dose within the dose comes to the normal level within 2 to 3 weeks. So immediately postpartum, we should not change the dose of the drugs. We have to continue maybe within 7 to 10 days. We have to again evaluate the patient, and accordingly you can reduce the dose just to avoid the postpartum toxicity of these anti-epileptic drugs. And as we told, because they are more prone to have a convulsive seizures during the pregnancy, post delivery. So because of the sleep deprivation, stress, all those things happens postpartum because of the baby feeding and all. In those cases, you have to be very careful because the risk of having a seizures are more.
Okay. So intrapartum, I think you said that all, and postpartum, what are the things that we are actually going to be doing? Okay, thank you.
The only indication for cesarean would be a status epilepticus, which is not
Yes.
coming under control, and
Yes.
we need
Yeah.
to do those things.
There is a next
Or
question.
maybe, due to seizure patients, like some
Just
people.
wanted to add one thing, one interesting thing which we had saw in Stanley under Professor Dhanraj. We looked into all the patients who are on AEDs. You know, most of them had only the conventional AEDs was only available in government hospitals those days, where they are either eptoin, phenobarbital, eptoin, valproate, and carbamazepine. These are the only drugs available. So we looked into cesarean sections done by in RSRM. We looked into all the cesarean sections done on epileptic patients. We just wanted to have a look at that. What was surprising is patients out of the 160 indications, majority of them were on valproate. Then we looked into the indications of what was the cause for this increase in valproate. It was not significantly, but 9-10 cases for carbamazepine and only 2-3 cases for eptoin, and nothing for, but majority of the cases were only for valproate. And surprisingly, the most of the indications on valproate induced cesarean section was uterine atony. And so then we then started monitoring the uterine contractions in patients who were on valproate, and we realized that the contractions were very poor. They did some I don't know what some uterogram. They measured the contractions. One of the gynecology PG did the research work, and then we came to and we published the data also. In the uterine atony of sodium valproate is very significant, and that was one other indication for cesarean, apart from the status epilepticus in epilepsy. This I just wanted to please acknowledge.
Okay. Okay, thank you. So I also wanted to ask Dr. Pave, status epilepticus in pregnancy, how would you want to handle?
Like you handle the status epilepticus in any other non-pregnant women, you have to handle the same way. There are no contraindications of giving drugs because it is a life and death scenario.
Yes.
You have to take care of the mother as well as the baby. So you have to go as per the status epileptic guidelines for management as in a non-pregnant woman.
Should we terminate pregnancy when they get into status epilepticus?
Not necessary. It is not necessary to terminate pregnancy if you are able to bring the seizure under control. That is not an indication for termination of pregnancy.
Thank you.
You do expect some fetal distress during status epilepticus, but if it does not recover, then probably that is one of the.
Okay. I mean, all the time that status is there, it need not necessarily end in a termination. What is a first-time seizure or a new onset epilepsy during pregnancy? Sir, can you throw light on this?
First-time seizure in non-pregnancy, there is no issues because you can wait and watch.
Okay.
We don't jump on start onto any drugs. In fact, most of the first seizure experiences says that there's no need to start on drugs immediately until you can evaluate and wait. But whereas in pregnancy, there are two things. You have to be very, very careful about the semiology of the seizure, because if it is a focal seizure, I would definitely go flat out to see the neuroimaging and an EEG to make sure whether the seizure is focal. Invariably, focal seizures becoming secondary generalized is what happens happens in pregnancy, and so the evaluation of the first seizure in pregnancy, first time onset in pregnancy, has to be elaborate and make sure that there is no organic lesions which are the cause.
Okay.
Even sentinel bleeds, madam. SAH sentinel bleed will throw a small seizure from a bleed from an aneurysm. Small sentinel bleed, a warning bleed in aneurysm will provoke a seizure because blood products are very irritable to the neurons. So first seizure during pregnancy, I will go flat out to rule out an organic cause.
Very good. Okay. So I think you spoke a little about CVT as a cause of seizures during pregnancy in your dialogue. Would you want to add anything to this, sir, or Dr. Pave? Would you want to add?
No, sir has spoken everything in detail about CVT. I think nothing is there more to add.
Right. Okay. So this is something that I just went through and saw the case report. A 32-year-old woman had seizures and coma due to severe hypoglycemia with a value of 26 milligrams in the 32nd week of an otherwise uncomplicated pregnancy. So she responded dramatically to the administration of cortisol, and initial endocrine evaluation disclosed prolactin, corticotrophin, and thyrotrophin deficiencies. The patient recovered completely with cortisol and thyroid hormone therapy and was delivered of a healthy male child. And she had history of seizures, which I think for the first time. And she was for a short period in coma. I just wanted comments on this because this is the first time that she's getting into having seizures in pregnancy. And this is a scenario. I just wanted your comments.
Start her on IV line and immediately call the neurologist for it.
Yeah, that's why I'm asking the neurologist now. It's a little bordering on to the endocrine, but I thought this is a case report that I went through.
I'm seeing the non-diabetic? No.
No, nothing else was actually there. Very severe hypoglycemia secondary to these deficiencies causing seizures. And she was in her third trimester of pregnancy.
Sufficient to produce a seizure.
Sir, I think you were muted for a while. Can you just repeat?
I thought it was a hypoglycemic seizure.
Yes.
And it is a and a pan-hypopituitarism. Probably, I don't know whether it is a Sheehan's or something is going on there. The thorough evaluation of endocrine is essential. And this amount of hypoglycemia, will also do a insulin assay because the few of these insulinomas get unraveled by pregnancy. I have seen a couple of cases where the levels of insulin were in thousands, precipitating the administration of cortisol, and they persistently remain to be hypoglycemic, and then the search for insulinoma was done. That patient was around 33 weeks, so they took up for cesarean along with the surgical gastroenterologist who probed for a insulinoma and then found that an islet cell had a small insulinoma. So that's all incidental which I saw. But this case looks like an hypoglycemia seizure, the pan-hypopituitarism.
Yeah, I just wanted to put, because just to know that there can be other reasons that can cause seizures during pregnancy. So this is another woman who had the report says she had intractable focal epilepsy which deteriorated, and she required an emergency neurosurgery. How often do we have patients who really go ahead requiring neurosurgery during pregnancy? Any thoughts on that?
Madam, there are certain tumors which have estrogen receptors on the surface, which get flared up during pregnancy. There are hormone-sensitive tumors, which are neurological tumors, which produce focal seizures, like they present as epilepsia partialis continua. Because continuously they will be seizing to the extent that they'll have to be taken up for craniotomy and the tumor has to be removed. They all show, like a breast shows ER-PR receptors. There are similar receptors there. Even a few of the meningiomas, not necessarily within the brain. The meningiomas can also produce a seizure by just impinging on the brain, which have a lot of estrogen receptors on the surface. So there are a lot of hormone-sensitive SOLs which are present in the brain, and the neuroembryonic tumors also have the estrogen receptors on their surface, which all get aggravated and present as epilepsia partialis continua.
So I just have a question. Do all lesions in the brain require an intervention during pregnancy? Because we may have to terminate and prioritize a surgical management. Or are there any lesions where you feel that, let's say she is in late second trimester, we can move on, deliver her, and then handle her with a surgery?
For example, cavernoma. Cavernoma will again produce a focal seizure. A frontal lobe cavernoma, a small bleed which will happen into the cavernoma, which will produce a seizure, a couple of seizures. But what happens is, if you look at a cavernoma, it doesn't have a feeder or it's a very closed space where the bleeding happens into that. And so it is self-limiting. You don't have to do anything about it. You can wait until the pregnancy gets completed and you can safely monitor. And there are a few benign, even DNET, madam, for that matter, the embryonic, dysembryogenic tumors, they throw 1 or 2 seizures and they don't continuously. Unless the patient, since you are put as intractable focal epilepsy, that required a neurosurgical. Most of the focal epilepsies, like benign lesions in the venous angiomas or cavernomas, can always be quiet and they don't trouble you much. You can continue the pregnancy.
Okay, so this is something I looked at, and it says there's a history of right temporal lobe epilepsy since the age of 9, and she presents at 25 weeks and 5 days with recurrent focal retained awareness seizures. So these seizures were described as left arm clonic jerking and left eye deviation with preserved consciousness. So how does this course happen in pregnancy if this woman is just about 25 weeks?
This is only a complex.
Still has a long way to go.
Madam, this is only a complex partial seizure.
Yes.
And carbamazepine is the most sensitive drug for this kind of seizures. What she is having is these motor automatisms, and the left eye deviation, she says that it is spreading onto the frontal eye field in the frontal. So the seizure focus looks like left frontal and left temporal.
Yes.
They will be very much amenable for the carbamazepine therapy. And step up the dose, we can go to any amount because it's harmless and they will settle. And as consciousness is preserved, there is no issues on things like seizures. I think by stepping up the titrating the dose of carbamazepine, we will be able to reach the pregnancy to a compatible level. The child will become, until the child becomes viable, and another few weeks if she survives with this, and I think you'll be able to take her out by cesarean.
Okay, yeah. When will you advocate polytherapy in epilepsy during pregnancy? We always talk of the single drug to the maximum dosing during pregnancy in a general rule.
See, the Thanpa, would like to say anything?
No, sir, you can tell, sir.
See, normally, polytherapy, we don't initiate a polytherapy in pregnancy.
Yes.
But what happens is the patients who are on polytherapy, they become pregnant. In that case, where the polytherapy comes only because they are not able to control with a single drug. Then the doctor adds a second drug to control. So sometimes the drug trial keeps on increasing the list of drugs where the patient will be on a polytherapy with different mechanisms of action to get a good seizure control. What most of the neurologists, what they will do when they are on polytherapy, when they are in the pregnancy, when they are in the reproductive age group, what they try to do is adjust all the drugs which are in the polytherapy to the minimal requiring levels so that the teratogenicity is less and they will be able to go through the pregnancy. These are all highly subjective, individual, not evidence related polytherapy. But we have seen so many girls who are on refractory therapies, childhood, on multiple drugs, AEDs, coming through successfully, having a good delivery and brilliant children. There is nothing that polytherapy is.
Actually, my question was not somebody who's been on polytherapy prior to pregnancy. My question is someone who's been on
We do not advocate polytherapy in pregnancy, period. There's no second. Invariably, we try to use a single drug, step it up to the maximum dosage to see that the seizure gets controlled. We don't go on for an add-on in pregnancy.
Okay. This question
unless they are already on polytherapy.
On polytherapy. Okay, this is for Jaya ma'am, because I think she did speak about sleep deprivation. So how much influence do you think, ma'am, that sleep deprivation can have in triggering seizures in a woman who's already an epileptic?
There is evidence that sleep deprivation does trigger seizures, but it cannot be helped. It cannot be helped. So the patient has to, particularly when she's feeding the baby, it may not. So we just tell them to catch up as much sleep as possible when the baby sleeps.
Time.
So
Yes.
that's how we try to balance the sleep deprivation.
Yes.
Practical.
We try to get them to sleep in the daytime, and how much they are going to sleep, I don't know. Sir, this is actually, we had a patient some many years ago, but I thought I should just put this case up because we had a couple of patients who had this. So they had 4 convulsions. They came in the second trimester of, one was in second trimester and the other was in third trimester. Marginally raised blood pressure, nothing very significant. And focal convulsions they were having. And the MRI revealed spherical ring enhancing lesions in the brain. And neurocysticercosis was the diagnosis, and both patients delivered well and had a very good outcome. But I thought I must listen to you.
Madam, whatever the investigations reveal that the patient had hypertensive disorder of pregnancy, and the detection of neurocysticercosis is incidental. And neurocysticercosis, as you know, that they are well adjusted with the brain. They live comfortably. They don't disturb the brain. I except throwing a few seizures with a long interval period. Between the inter-seizure period is pretty long. They see neurocysticercosis, especially solitary ring-enhancing lesions like this, which the inter-seizure interval is pretty long. So you will be able to easily, they will be able to tide over a pregnancy, and nothing much happens. The neurocysticercosis is nothing hormone sensitive in that. So they live quietly, and I think there is no surprise for me. There's no surprise that they pass through this pregnancy. A lot of people, you detected it because you did an imaging. Otherwise, they go undetected.
Okay, but we are not used to pregnant women having focal seizures in pregnancy. So it is moments of anxiety for us. Thank you, sir, for that.
What about the BP and the albuminuria?
No, one of them just had a marginal rise in blood pressure with 1+ urine albumin, and she did not require antihypertensives. It was just an incidental finding, and then she went through the pregnancy without any further rise in blood pressure.
Anti-helminthics are not required, madam. Anti-helminthics.
I was just going to ask you that. Okay.
It is not required. At least not in pregnancy. No need for anti. Just
what about purparium?
Madam, even in purparium, we don't start them on anti-epileptic, and we maintain only with anti-epileptic drugs, not on
anti-helminthic. Okay, that's a great
corporate review for anti-helminthics on neurocysticercosis. I have done that, madam.
Okay. This question is for Dr. Sunita. I know that when postpartum woman has seizures, we always do some kind of a higher imaging, because it's not just eclampsia, even if it happens within 2 days.
Yeah, so there can be, as you told, it can be pressed like reversible, posterior reversible encephalopathy syndrome. So here it happens like mostly patients will present with the previous history of having pre-eclampsia, eclampsia, or patient having some sepsis or immunosuppressive therapy, or having any renal disorders. These patients are more prone to have a press, and they present with one is a convulsion and with the acute confusional state, and mental alteration will be there, and also there can be acute cortical blindness. And in the press, that headache, they present with a very typical headache that we call as a thunderclap headache. Very acute, severe headache they present with. And treatment, how we manage, we manage the BBP is high, we manage with the IV labetalol, and also this magnesium sulfate therapy, that is the treatment of choice. And along with that, because in a place there is mostly this parietal and the occipital lobe are involved when you do MRI, so you can to control this vasogenic edema. Sometimes you can give the mannitol also, anti-edema measures, and just symptomatic management we do for the press.
Okay. Yes.
No, I was just wondering, is there a line which we can draw between neuroimaging and not doing it and treating it as a straightforward eclampsia? I mean, I should not be asking questions in the panel. I'm supposed to answer. But I just thought, because our PGs just asked MRI, MRV, left, right, center. They call the neurologist and immediately PG comes and immediately writes and they rush the patient for this MRI.
I think,
So
ma'am, any
this is all
postpartum.
happening in the last 5-6 years and not before that. We used to treat eclampsia ourselves. We never used to call the neurologist. But of late, we are also falling into line. So I just wanted to have a highlight on this.
Now, maybe somebody having like atypical type of eclampsia, like in a postpartum period, as like a CBT and this press and all.
That we say localizing signs, not arousable, status epilepticus, and beyond 2 days. These are all standard guidelines for MRI imaging. But once fit, immediately MRI is being asked. So, what do you say, sir?
I think I would do an MRI, ma'am, in a postpartum period. As the neurologist says, sir, you're just putting your hand on your chin. Please tell me the answer.
Madam, for us, puerperium, any seizure in the puerperium, even though it is postpartum eclampsia, is very much on the cards. We will do an MRA, MRV, yes. MRA. And make
I
sure
think I am with sir. Thank you for that. Ma'am, Jaya ma'am, this is for you. I think women get apprehensive about
I will immediately call the post-value right MRA.
On lactation, what would be your advice or education on lactation for these? Because they are a little apprehensive. Can I feed my baby? Will this harm my baby when she's on drugs?
I think most of the drugs are safe in pregnancy. Very little of them is secreted into the breast milk. So I think breast and whatever drugs we are using nowadays are very little of them get secreted in the breast
milk. Okay. Okay.
None of the newer anti-epileptic drugs, till whatever drugs, nothing is contraindicated for breastfeeding.
Right. Sir, can these women who are epileptics or who have focal seizures and who are on drugs or polytherapy, can they drive vehicles during pregnancy?
No. Big no.
Thanks for that, sir. That's a real emphatic no. Okay.
Madam, just to recollect one incident, recently, one epileptic person, in spite of my repeated advice, he went to pick up his son in one of the city schools. He developed a seizure while driving. School was children. Imagine, complete loss of control. 4 children got admitted with multiple fractures.
Oh my God, sir!
I knew that the moment I saw all the 4 children in the hospital getting admitted, I felt so bad, and I scolded him left and right. No driving during pregnancy. Safe not for him also, but also for the society.
Okay.
Because maybe it added a lot of stress during driving because of traffic. That also may aggravate the seizures.
That's a different topic altogether. Sir, current guidelines, I think we already discussed. So I will skip this question because you already said there are some very safe drugs. This is a report that I saw where a woman has had generalized tonic-clonic seizures following a spinal anesthesia with bupivacaine for a cesarean section.
I mean, I don't know, but the bupivacaine is supposed to be the...
for labor analgesia, we give routinely bupivacaine for labor analgesia also.
But I think there are some cases reported with epidural.
I saw it in the literature also. Bupivacaine should be avoided.
In epidural.
And, for nerve blocks, we use nerve blocks we use.
Dose related.
Yes, sir.
No.
For nerve blocks, we use lignocaine only instead of bupivacaine.
I also read that with epidural, it's more reported, and this was very rarely reported after a spinal. I just thought I should be getting your opinion. Okay. Cerebral malaria causing seizures during pregnancy.
The commonest cause of seizures,
malaria is known to cause
plasmodium.
Madam, the commonest cause of seizures of cerebral malaria during pregnancy is hypoglycemia.
Okay.
Because the cerebral malaria, one of the important complications is you have to just check the CBG and then give sugar. The second thing is most of this Plasmodium falciparum, they clog the arteries and For diagnosis of cerebral malaria during pregnancy, a look at the fundus is very, very important, because malarial retinopathy gives a violaceous hue to the vessels. You'll never forget once you see the malarial retinopathy is characteristic. So a patient unconscious, when you want to look for a cerebral malaria, we look at the fundus. The malarial retinopathy will have the hemorrhages, white dot hemorrhages. They're called white dot hemorrhages. And the classical intravascular hemolysis produces a violaceous color to the, it's beautiful. The fundus, you look at the picture, you can see in many journals it's been published, and it's a beautiful color. The postgraduates, once he has a look at the fundus, will never forget that this, you can boldly start treating with the anti-malarial therapy straight away for this. There are many number of artemisinin combinations available, but WHO pregnancy regimens are also given in the guidelines, what they call it as what is it, the artemisinin and AAT, artemisinin and anti-malarial therapies. There are about 16, 18 regimens, 12 or 13 is for pregnancy.
Yes, and I think even
WHO guideline. The book is free, madam. Ask the postgraduates to download the malaria guidelines that is released by the WHO. Beautiful, very, very, very concept.
Yes, thank you, sir. I think that's a great point, that most common cause is hypoglycemia, low blood sugar, that triggers the thing. I think I'm coming towards my last slide. Acute fatty liver causing seizures in pregnancy. Ma'am, you'd like to take this, or shall I ask sir?
No, I don't have experience in this acute fatty liver causing seizures in pregnancy. Other there is features of liver cell failure producing hepatic encephalopathy and seizures.
That is one thing, and hypoglycemia is another thing.
Yeah, here again hypoglycemia. Yes, here again that probably triggers it. Sir, you want to add?
Was a patient was on valproate?
No, sir, this is only acute fatty liver pregnancy, AFLP in pregnancy.
So mostly maybe that fulminant hepatitis, like leading to cerebral encephalopathy, that can cause this kind of convulsion.
Yes. So there are some very rare reports of AFLP causing seizures in pregnancy. I thought I'll just put all the possible causes in pregnancy. I think I just want to finish with a one-liner from each of the panel member. One thing, if you want to give it as a take-home message at the end of this exhaustive panel, I'll start with Jaya, ma'am.
Any seizure in pregnancy, unless proved otherwise, is eclampsia. That's the first
golden line. Yes.
Generally occurs in the third trimester.
Yes. Ma'am, Dr. Sunita.
Yeah, so when patient is in a known case of epilepsy, so always you try to give a single drug therapy with the lowest possible dose, so that to avoid the congenital anomaly, and also side by side to control the seizures during the pregnancy.
Thank you. Dr. Pavai.
All my seizure epileptic patients, I've asked them to disclose the seizures before pregnancy for good complaints during pregnancy. Otherwise, if they don't disclose, I feel so many of them withdrawing the drugs and land up with status.
Thank you. So I thought I should ask Master of Seizures the last. Sir, now for the final.
I request the obstetricians to involve the neurologist for any patient seizure. Will add value. Will definitely add value to management of the case, madam. But unfortunately, in my 30 years, I have very hardly had any reference of seizures for in pregnancy. The referrals are the least in my total career. I was thinking, I don't know why obstetricians feels that neurologists will not add any value to their management.
It's not that way, sir. Because when it comes to eclampsia,
the take-home message is we can definitely add value of in managing your case. Please involve us in the management.
Other than eclampsia, I suppose.
One thing we forgot regarding the contraception. Yeah. So particularly those who are taking anti-epileptic drugs in the postpartum period and enzyme-inducing drugs they are taking, in that case, they should avoid the oral hormonal pills. But for them, it is better is a copper tea. Otherwise, all non-enzyme inducing agents which a patient is on, they can take the OC pill. So patient has to be for contraception. That point has to be also counseled to the postpartum mother.
Thank you. Thanks for reminding me of that. Thanks to Jaya ma'am, Dr. Sunita, Dr. Pavai, and sir.
All of you would agree that Dr. Usha Vishwanathan's this was the most enjoyable panel I had in the recent.
There are some
all the questions chosen were very excellent.
Yes,
My
ma'am.
hearty appreciations to you. Thank you so much.
Thank you, sir. We are in the
Wonderfully-
same
Wonderful to
campus, but
enjoy
I
the
am
panel
seeing you
without
only.
leaving
Usha ma'am,
anything.
there are 3 questions in the question and answer box. Safe antileptic for bad obstetric history other than Levipil. Other than Levipil.
Lamotrigine, but be careful for looking for a rash, madam.
Lamotrigine, just look for the rash.
Oh, sir. Okay, sir. Is anti-epileptic drug associated with autism?
Oh God.
Yes, with
there
sodium
are anecdotal reports. Madam, please, madam.
Yes, usually it is associated with sodium valproate.
Sodium valproate.
Yes. Autism mostly. So usually we don't give sodium valproate because of the newer anti-epileptic drugs. We don't give sodium valproate in epilepsy patient during pregnancy. So that is mostly associated with the long-term neurological development and with autism.
Ablating of anti-epileptic focus in pregnancy. Ablation of anti-epileptic focus in pregnancy.
I think sir discussed that in detail. The lesions. He talked of cavernoma and he said there are lesions that can be continued. And only certain things.
There are few radio frequency, stereotactic radio frequency ablations are also coming up in a big way during pregnancy, madam. That's what probably the person who wanted to go.
Okay.
Yes, sir.
There are shields which carefully avoid any kind of radiations to the children, and they are very focused on the lesion for radioactive ablations. Either the gamma rays or the protons, but I think the level of evidence is pretty low.
Thank you, sir. Thanks to everybody who has been part of the panel. It's been a pleasure, and thanks to Dr. Rajshri, who has coordinated this, and of course the queen of Oxy, Dr. Jayarani Kamaraj. It goes without saying. Thanks to Dana too. Thanks everybody.
Thank you. Thank you, ma'am. Thank you, Rajastri ma'am, Dana ma'am. Thank you, Usha ma'am. It was a nice.
It's my pleasure and privilege to propose a vote of thanks. First of all, I would like to thank our beloved Jayarani madam and Kundavi madam. They have not only started the committees and initiated the webinar, they are also continuously encouraging us and guiding us to coordinate with faculties from other societies also. That's why we are able to involve so many people, because we get encouragement and guidance from them to say involve this, include them, and it's really an encouragement, and we are able to continue this webinars. I would like to thank Ashwath sir for readily agreeing to be the chief guest, and he had to reschedule the cesarean section. He said he's just waiting for the start of the webinar. He just postponed it a little for the emergency cesarean section and was able to take part as a chief guest in this webinar. Thank you so much, sir. Thank you, Kanchan madam, for sparing some time from your busy schedule and for your words of encouragement. It would be a privilege to be associated with you as chairperson of NCD committee in future, ma'am, and eagerly waiting for the day. Thank you, Tamil Pave madam. In spite of your schedule, both of you and sir, readily agreed to be a part of today's webinar, and you have really instilled some interest in us in taking care of pregnant patients with multiple sclerosis. And your talk was really well researched and evidence-based, and we really learned a lot, and we would like to read more about it and know about it also. Though we come through the cases rarely, you have initiated an interest in us to go through it and take care of the patient. Sir, when we decided on neurological problems in pregnancy and was searching for an ideal neurologist, it was Dana madam who suggested that please contact Lakshmi Narasimhan sir. And your enthusiasm and zest for the topic was really infectious, sir. And we immediately sensed that, yes, you will be the ideal person to heading this webinar for the neurological problem in pregnancy. And we are really very, very thankful to you, sir. You have very informative, and we really learned a lot. And yes, sir, We do want a neurologist and we will involve the neurologist. Your point is taken, sir. We can't handle all the cases by ourselves, sir. We do need you, sir, for all our cases. And Dana madam, really, ma'am, thank you for taking the initiative and for delivering the dialogue. And as usual, you rocked. It was a rocking performance, ma'am. Sure, madam, thank you so much. This panel, the number of cases, the interest that you have taken, and as Sir said, the various topics, the various cases that you have chosen, real interest, and it was a real interactive panel. All the cases that we could think of with, you took a real interest to take some time, put in these cases and make it a really very interesting panel. Jaya madam and Sunita madam, thank you so much for sparing your time, your experience to be a part of this panel and making this a very informative and a very interesting and interactive panel. Thank you again to both the neurologists for being a part of the webinar. Thank you, Sneha, for an excellent mock master of ceremony. Thank you, Shield, for the platform. And finally, the audience. Yes, you are the encouragement for us to continue this webinar. Thank you so much.
Thank you.
Thank you.